Let's get started. You could hear me okay, everyone?
Yes.
Thank you, everyone, for coming to this wonderful webinar. We have some wonderful panelists and guest speaker. So my name is Rennie John. I'm a worksite wellness coordinator with ACS, and I'll be the facilitator today. Today's workshop is about cancer care, knockout cancer, a discussion about men's health and cancer prevention. Let me first introduce these wonderful folks that I've worked with before, very knowledgeable about this right here. Dr. Leonard Litchfield, board certified medical oncologist and former deputy chief medical officer, American Cancer Society. Dr. Len is also a member of the Cancer Board of Trustees and is joint finance and executive committees. And we also have Patricia Goldsmith, chief executive officer of Cancer Care. And those are the folks that I just introduced. And a little bit about WorkWell. WorkWell NRC is basically for New York City government workers, the wellness, and we try to make sure that New York City government workers are their healthier so they could do the job for the community and folks of New York City. These are the buckets that we concentrate on a daily basis to make sure New York City workers are the healthiest in the nation. Today's objective: to increase awareness about men's cancer care risk, prevention and treatment, and learn ways to support the health of men and loved ones, and to answer any questions that you may have about men's health and cancer. We have a poll today, and Marissa, could you run the poll? Louisa, who do you identify within the group? Marissa, did you run the poll?
Yes, the results should be live.
Okay, got you.
Wonderful participation by 71% of men.
Yeah, I can't see the poll from the share screen, so.
Oh, well, just to summarize for you, Rennie, about 71% of participants identify as male and about 30% as female.
That's totally awesome, and that's what we were looking for. We're just really trying to get the men on board a lot of times with our programming, and this is very good to see. Thank you so much for everyone for participating. So please share in the chat, why did you join today's webinar? What are you trying to leave here with today? What kind of questions you want answered and stuff like that? I know a lot of folks had already submitted their questions, and we tried to get every question answered before we end this webinar today. So thank you, everyone. Thank you. So without further ado, Ms. Patricia Goldsmith.
Good afternoon, everyone. My name is Trish Goldsmith, and I have had the pleasure of being the Chief Executive Officer of Cancer Care for the last 8.5 years. I'll speak a bit more about Cancer Care services, but we are a 78-year-old organization based in Manhattan, but we serve anybody who has been impacted by a diagnosis of cancer. So not only the patient, but also their caregivers, loved ones, the bereaved. And we have a variety of pillars and programs that I'll talk to you about later. But I do hope that you will always remember Cancer Care. I always have the hope that anyone who's been diagnosed with cancer, their first call would be to Cancer Care. We're here to provide help and hope. And I have the pleasure today of introducing someone who is very near and dear to my heart, Dr. Len Lichtenfeld. He is a medical oncologist by training. He is an extraordinarily knowledgeable individual who's always so giving of his time. He is a member of our board of trustees and our finance and executive committee, and he is just a pleasure to know. So Dr. Len, I will turn it over to you.
Thanks, Trish, and Rennie, and all the colleagues at New York Workwell who have made this possible. It's really a pleasure to be with you, and have to say that I've been to your wonderful city on several occasions, including recently, and just so appreciate, quite honestly, the many courtesies that have been extended to me and how much I've enjoyed those visits. So it's very special to me personally to be here with you and to share some thoughts, and frankly, certainly welcome the men who are on this webinar, and also those who care for them, because for better or worse, one of the things you learn when you're a doctor over the course of time is that men are frequently not, sometimes, let's put it this way, reluctant participants in trying to keep themselves well and healthy. They have a lot of interests, a lot of other concerns. So your presence here today, of all of you, your presence here today to hear a little bit about cancer prevention means a lot to Cancer Care, means a lot to me, and I hope you'll find this helpful. So let's talk a little bit about who's affected by cancer. Ready, if we can have the next slide, please. I always want to point out, I do make it a point in essentially every lecture and every commentary that I give, to say that we're doing better, and we'll show another slide in just a moment. We're doing much better in terms of cancer and outcomes for cancer. The number of premature deaths or early deaths that are averted because of what we can do today. But we still have a long way to go. And I showed this slide because I think it's important to a lot of folks to understand that there are substantial inequities in outcomes in terms of cancer deaths and incidence as well. And we'll talk more about that in just a moment. But as you can see from this slide, and unfortunately I don't have a pointer, but you can see that certainly, in this slide, it goes from 1975 to 2019. You can see a much higher rate of cancer among Black men and Black women than comparable rates for white men and white women. And for men in particular, a lot of that was because of smoking, because of tobacco use. And I really take special note about 1975 because that's about the time that I started my career in oncology. And one of the little known facts is that among Black men, smoking decreased considerably compared to other population groups. And actually, some of the early data came out a number of years ago from New York City, where they saw a significant decline among Black youth. Well, that's played out over time, and you can see that the death rates in Black men have dropped considerably, but they certainly haven't gotten back to equity. And that's something that we need to pay attention to for Black women as well, in no small part because of outcomes related to breast cancer treatment and others. One other point that I like to make, and I think is important for everybody to understand, back in the early 1970s, before the time period before this slide, the outcomes for Black men and Blacks and whites was not that different when we talk about certain cancers, such as breast cancer and colon cancer. And it's only been with the increase in screening, the increase in improvements in treatment, that these gaps had widened and are beginning to narrow, but have not narrowed enough. And so when people say, well, it's a different disease, no, it's not necessarily a different disease. It's because of a lot of other factors, not the least of which is access to care. And even as Rennie pointed out, the city of New York has made every effort to make sure people have insurance, that they have access. And that's important to improve outcomes. Not everyone, as all of us on this webinar know, not everyone enjoys that equal access. And until we get there, we are still going to have disparities in care. So having said that, if we go to the next slide, I do want to point out, just so everybody's clear, we have had substantial improvements in reducing early deaths related to cancer over the course of the same period of time. And in fact, if you can look at this particular slide, the estimates are about 3.4 million, 3.5 million early deaths have been averted since 1990. The blue line is where we were, the curve we were in 1990. You can see that line begins to bend. The red line is where we would have been had there been no change in outcomes. So we've made significant progress, and we've made progress in all groups, but we clearly could do better in some groups, particularly the people of color, as we go forward in trying to improve outcomes from cancer diagnosis and cancer care. Next slide, please. So Cancer, the frequency of cancer, and when we talk about rates here, these are the number of people who get cancer over the course of a year. And it's a statistical, I don't want to take a lot of time getting into statistics here, but you can see that when you talk about Hispanics actually have a lower rate than other racial groups. And Asian Pacific Islanders have the lowest rate of all compared to different groups. But Native Americans have higher risk of cancer. Non-Hispanic Black men have a high rate of cancer. Non-Hispanic white men also have a high rate, somewhat lower than non-Hispanic Black men. And for women, which is not the target of this particular conversation, you can see the comparable numbers there. But this is the key point. The rate of cancer is higher in non-Hispanic Black men, higher than any other racial group. And I bring that to your attention in the hopes that people understand that we can do a lot more in terms of lifestyle. We can do more in terms of cancer screening. We can do better in terms of access to care and cancer treatment. And if we made it equitable, we could drop these numbers of both the cancer rates and also cancer death rates significantly. It's estimated, by the way, if we did everything we know what to do, that we could avoid perhaps about 40-some%, low 40% rate of cancer. That means 4 out of 10 cancers, we might be able to avoid them entirely. If we did what we already know, if we did what we already know works. Next slide, please. So with Black men, prostate cancer remains the most commonly diagnosed cancer. You can see the 37% of new cancer cases occur in Black men occur with prostate cancer. Lung cancer also has a high rate, 12% of new cancer cases, and colorectal cancer is about 9% of new cases. But when it comes to cancer deaths, 22% of them are due to lung cancer. That's the leading cause of cancer death among Black men. 17% of cancer deaths in Black men are in prostate cancer. And quite frankly, that reflects the fact that prostate cancer may be more aggressive and more common in Black men. Can we have the next slide, please? If we look at Hispanic men, once again, prostate cancer is the most common cause of cancer among Hispanic men. Lung cancer is actually a bit lower among Hispanic men than it is in the general population. Colorectal cancer is somewhat higher. But among Hispanic men, liver cancer remains a serious problem. Perhaps men came from other places where they didn't get hepatitis B immunizations. And those are the kinds of factors, and residence and place of birth have a lot to do with what cancer, and what you're exposed to may have a lot to do with what kind of cancers become more prominent. But liver cancer is a particular problem among Hispanic men, and also leads to a substantial percentage of cancer deaths in that group. Next slide, please. But I want to make some points here with these next 3 slides to talk a little bit about the differences of specific cancers in specific groups. And when we talk, the one you see on the left there, incidence rates, that's information that comes from national statistics and through the American Cancer Society, talking about which groups have the highest rate of certain cancers. And you can see from this slide that colorectal cancer, Native Americans have the highest rate of incidence. But Hispanic, non-Hispanic Black folks, this is men and women. And among that group, colorectal cancer is also much higher than it is in non-Hispanic whites. For death rates, however, non-Hispanic Blacks have a death rate that's higher than it is for whites, significantly higher. So you can see here the number, and again, it's a statistic, but it's 18.1 per 100,000 per year. And for whites, it's 13.4. That's a pretty significant difference. That means about almost a 50% greater chance of dying for Black folks compared to white individuals if they have colorectal cancer. And one of the reasons, once again, is when that disease is diagnosed and how it's treated. And the reality is, for colorectal cancer, we can screen for that disease. And we can find it early. In fact, in colorectal cancer, we can find it before it even becomes a cancer. We can find a polyp, and we can prevent that polyp and going on in an individual and actually causing cancer. New York City actually was one of the first cities in the nation to have a very aggressive program to promote colorectal cancer screening. These numbers are not specific for New York City. These are national numbers. But we have to bear in mind that there are cancers where we can make a difference, where we know from our research that if we screen for that cancer, we can find it early, we can prevent progression to colon cancer, and we can avoid a cancer death. So it's really important that colorectal cancer screening be up to date. Next slide. When we talk about prostate cancer, I've already mentioned this, prostate cancer has a much higher frequency of the number of times that it occurs among Black men than it does in other racial groups. And it's you can see here, non-Hispanic whites, the number is 99.9, so it's 100 versus 172. For Hispanic men, it's lower than it is for both whites or Blacks. But among Black men, the frequency of prostate cancer is much higher. And if you move to the right hand of that slide, you see the death rates are also much higher for prostate cancer in Black men. Now, part of that is unfortunately because prostate cancer is believed to be more aggressive among Black men than other racial groups. And it also has a tendency to occur at a younger age. And so you more often will find younger Black men and Black men who have a family history of prostate cancer, who then in turn are at higher risk of getting prostate cancer and dying from prostate cancer. And we'll talk a little bit about screening and the importance of screening and what it means. And prostate cancer may mean something different for Black men than it does for the other groups who have a lower incidence of prostate cancer and do not have anywhere near the death rates for prostate cancer that you see among Black men. Next slide. But this is an interesting slide. It's still not great information, but something we need to be aware of. Remember, I showed you before that the rates were coming down for Black men compared to white. Well, actually, more recent data, that's what we're seeing here. You have the incidence rates of lung cancer. That is, how often is lung cancer diagnosed among different groups. You see that on the left, and you can see that it's actually reasonably close in terms of frequency among Native Americans, among non-Hispanic whites, and among non-Hispanic Blacks. But what's been remarkable is that over time, the death rates between whites and Blacks have come pretty close together. Now, that means that there's equity, but it's not the best kind of equity you'd like to see, because ultimately, not every lung cancer is preventable, but many of them are. And the message of the day is that tobacco and smoking is related to lung cancer. And we do know that if we stop smoking, that we can reduce death rates. But I also want to make another point that I think is important. Lung cancer suffers from a stigma, and the stigma is longstanding. It's in the community, it's among health professionals, among doctors, and that is, if you get lung cancer, then you cause lung cancer, and it's sad, but nothing much we can do about it. And that's far from the truth, because what's happened over the past several years is we have much better ways of finding lung cancer early. We can make a difference in outcomes. Our treatments are better. So aside from just smoking cessation, we can actually reduce the number of cases of lung cancer and the number of deaths from lung cancer by doing the things we already know work: not smoking, getting screened, and also proper treatment. Next slide.
Dr. Len, there's a question in the chat asking whether or not these lung cancer rates are measured for men of all ages and all socioeconomic statuses.
So these are what, well, when you say all races, I mean, these are broken down by race, as you can see on the slide, okay? These are national numbers, and they're all socioeconomic status. So one of the things we know, so we're frequently, in this conversation we're having today, we are talking a lot about ethnicity, we're talking about race, but in matter of fact, that's an excellent point, Trish, it's an excellent question, because if you went and looked at this differently, if you looked at it by rural and urban, if you looked at it by highest grade of education, if you looked at it by straight economic status, you would see significant differences among groups. And we frequently have said, we understand from our research, if everybody, and I'm not saying that college educated people are perfect, that's far from it. That's not the message. But if everybody had the same behaviors as those who had some college education, we would have much lower rates of cancer. So a lot of it has to do with educational status, and a lot of it has to do with socioeconomic status. Some of it has to do with where you live, because in some parts of the country, lung cancer, for example, areas that have very high frequency of lung cancer don't have screening and don't have treatment capacity. That's not the case in New York. New York has access to care. We're having this conversation today because the employees of New York City have insurance, which is a major indicator. And access exists within New York City, and the capacity to get screened for cancer, to have those conversations about prostate cancer, to get lung cancer screening, to get colorectal cancer screening, that's available. And so these are, again, that's a long answer, but these are specifically national numbers broken down by racial identification. And let's also be sure we understand here, race from a lot of our perspectives is a social construct. It's not a biological one. What does that mean? That means that if everyone has access to care in a number of studies, equal access to equal care, these numbers all come down. They come together. Next slide. Go on.
And I will.
We're on the question. So here we are at a question. So, okay.
So a comment, and then Dr. Len, there were a number of participants that submitted questions in advance of this. So I'll walk us through them. But since we have been talking a lot about screening and the importance of screening, I want everyone to be aware that Cancer Care has a free program called Time to Screen. And specially educated social workers are there to take your call, answer your questions and your concerns, help you to find open screening sites. So please just be sure you take advantage of the Time to Screen program. So we've had a lot of questions submitted, Dr. Len. I know we probably won't get through all of them, but we have about 20 minutes or 20, 25 minutes. You talked a lot about, of course, the steps that can be taken to prevent cancer with respect to lung cancer, not smoking. But what are other steps that men should know about that can be taken to help prevent these common cancers?
Well, we are going to be talking a little bit as we go along here after we answer the questions, but we do have a summary slide so people can remember to take a look. We talked about smoking, diet, trying to maintain a normal weight, and trying to have a diet that a little bit less on the red meat side and a little bit more on the plant and vegetable side. Exercise, and there are a lot of people who are on this call, some of whom may be like me. You may be desk bound, but a lot of folks, hopefully the people who work in the city, a lot of people have jobs that they have to be up and around, whether it be walking from place to place or doing physical labor. So maintaining physical activity, watching one's diet, maintaining weight, keeping alcohol, frankly, as low as possible. There really is no safe level of alcohol, but if you go to the guidelines, they'll say one drink for women, 2 drinks a day for men, but in fact, understanding there's no safe level. Those are the kinds of things that you can do. But in addition to that, making sure that you're going to do better if you have access to a regular source of health care, a person or a place that you can get health care. That makes a big difference. And among the cancer screenings, we've talked about colon cancer screening, we've talked about lung cancer screening, and for men, the conversation should occur about prostate cancer screening. We haven't talked about specific recommendations there because, colorectal cancer screening for people at average risk. Now, if you have a family history, you got to talk to your clinician, the person who gives you your health care. If you have a family history of any of these cancers, and for women, for breast cancer, for example, you need to have a conversation if you have a family history and determine what the right screening is for you. But if you're at average risk, you don't have a family history, colorectal cancer screening beginning at age 45. If you've been a smoker in the past, if you smoke what we call 20 pack years, and pack years is how many years did you smoke and how many packs a day. So if you smoke 2 packs a day for 10 years, that's 20 years. If you smoke 1 pack a day for 20 years, that's 20 pack years. Number of packs per day times number of years smoked. And if you have been a smoker within 15 years or non-smoker, you stopped within the past 15 years, then you should start getting screened at age 50 to age 80, start getting screened every year. So that's just a real quick synopsis, a real quick summary. But for prostate cancer screening, that's a conversation you have to have with a clinician, with somebody who gives you medical care to decide if you want to do prostate cancer screening. That's not an automatic. And there's a tendency for Black men to recommend prostate cancer screening because of all the reasons I mentioned before, the frequency of prostate cancer and the death rates from prostate cancer. And some organizations actually recommend that Black men start at age 45. The more general recommendation is age 55 to age 75. So a lot of complicated stuff there, Trish, but eating well, exercising, avoiding red meat, avoiding alcohol. And yes, I know people say, well, those are the things that I enjoy doing. Well, you know, I do too, but we all do. But those are things you have to pay attention to. Getting screened, knowing your family history, having a source of care. Those are the kinds of things that can make a difference in reducing your risk of cancer.
So we have a question that came in from the chat, and then there's a part 2 that came in advance. From the chat, the question is, how is lung cancer screened? What is the process? Is it an X-ray or something else?
So excellent question, and thanks for asking it. So there's been a lot of research on trying to figure out what's the best way to screen for lung cancer. And frankly, a lot of it's been done in New York City. But we use what we call low-dose CT scans, CAT scans. And it's itself a harmless procedure to get screened. You should have a conversation about, once again, so you understand what screening is about. But it's a low-dose CT scan, and if there's something that's found, let me see how I can phrase this. Over time, since we've been recommending lung cancer screening for close to a decade right now, but over time, we've learned a lot more about what's really a problem that we see on a CAT scan and what's not a problem, or what we need to follow. But if something shows up, then it's important to have the follow-up. There may be additional studies that have to be done, but it's a lung scan that should be done every year, beginning at age 50 through age 80. And if you're a current smoker, and if you're a past smoker, up to the time when 15 years from the last time you smoked a cigarette. So again, it gets too complicated. But the point is that your clinician should talk to you about it so you understand. But it's a CAT scan. And if anything suspicious is found, they'll likely recommend either an additional CAT scan or doing some additional tests to try to find out exactly what is wrong with what you see in the lung. It's never good news to find a cancer, but it's always better news to find that cancer, particularly lung cancer, early, when it has a much higher chance of being cured than waiting, as we used to do in the old days, until you showed up when you had some cough or you're coughing blood or your voice went hoarse. It's much better to find it when it's a little dot on a CT scan than it is when it's a much more serious disease.
Dr. Lin, someone submitted a question asking, are there any routine screening tests that I should avoid? And specifically, they asked about the mail order colorectal screening test.
Well, that term mail order colorectal cancer screening test can mean a lot of different things to different people. There are tests, and there's one that's advertised on TV and it's generally available. And it looks at you literally package up a stool sample, a bowel movement, and you put it in the box and they send it off to the lab. And that test has been shown to be helpful in finding cancer early. So that sort of mail order test is okay. Some people may consider what we call there's a stool. There are different other kinds of tests where you actually go into the bowel movement in the bath, in the toilet, and take a sample and put it on a card, and you may send that in. And that's okay, so long as you're doing it with somebody you know, a hospital, a lab you know, and that somebody's going to follow up if there's an abnormal test. And by the way, if you do any of these tests, like the one I told you where they take the box and you send it in, or if you do the one where you scrape the thing and you send that test in, make sure you get an answer. Don't assume that no news is good news, because even in my own personal situation, in my family, things get lost in the mail. So you got to make sure you get that result. So those kinds of tests are okay. On the other hand, what you may also have there, some people are recommending tests where you breathe into a mask and they have a dog sniff cancer. Those tests have not been proven. There have been some research to say that they might work under very specific circumstances, but when applied to large numbers of people, it's never been shown that those tests are either accurate or as effective as the tests that we talked about before, the blood test for prostate, the lung cancer screening test, the various tests you can get for colon cancer. What's interesting going forward, and you're probably, some of you may have already heard about it, there's increasing interest in doing blood tests to find many cancers. Sometimes it may be specific for a colon cancer in a blood test. Sometimes it may say we can find lots of cancers. Those tests are relatively new. They can find cancer, but they can also miss cancers, or they may send a signal there's a cancer and they can't find where the cancer is coming from. So those tests are not generally covered by insurance, and they're still, although they're in a sense from the science point of view, they're exciting. There's still more that we have to learn about how to use those tests the best way possible.
So, Dr. Len, another question sent in advance, and I think this really focuses on the three cancers that you've talked about with respect to being most common in men. What are the signs of these cancers? What should I be looking for with respect to colorectal cancer or prostate cancer?
Well, I'm going to say something, Trish, that I don't want to hurt anybody's feelings, but I would want to find any of these cancers before you have a sign, plain and simple. The whole point of what we're talking about is to try to find a cancer early. So with lung cancer, if you find it by screening, you hopefully don't have any signs. Having said that, if you develop a cough, if you develop shortness of breath, if you develop hoarseness of your voice, or I mentioned difficulty breathing, sometimes people have unusual symptoms. They may have a drooping eyelid or a change in the pupils in the eyes. Those are really strange things. But hoarseness, cough, coughing up blood, that's not something that's something you have to see a clinician, a doctor, as soon as you possibly can. On colon cancer, it's the same thing. Once you start to have, in years past, we used to call it an early sign, but now we know that the best way to find a colon cancer is before there is any sign. But abdominal pain, trouble with bowel movements, constipation, having blood in the bowel movement, having black tarry stools, or the black in the stool may reflect the cancer somewhere else in the GI tract. Some people present with anemia, so they may have generalized weakness. But particularly if you see blood in the stool, that's a sign you need to see a doctor. Now, depending on the situation, it may be nothing more than hemorrhoids, but don't assume that if you have blood in your bowel movement, that it's because of a hemorrhoid. And prostate cancer, most prostate cancers that are, sometimes they may lead to a change in how often a man has to go to the bathroom to urinate. If you urinate more often, for example, or getting up a lot at nighttime. But if there's good news in that situation, it's usually more often than not because of cancer, it's because of something else. But if you notice a change in stream, or if you notice blood in the urine, for example, obviously, if you have blood in the urine, no matter what, you should see a health professional as soon as you can. But again, I'm going to come back to the fact that we would like to find these cancers before they have symptoms, when they're easier to treat. Again, in prostate cancer, I keep coming back to prostate cancer because that's difficult. There's no firm recommendation for every man to be screened for prostate cancer. The recommendation is you should have a conversation with your health professional about the pros and the cons of prostate cancer screening. A lot of times, unfortunately, most prostate cancers, most don't have to be treated immediately. Some people don't ever have to have treatment, even if they have prostate cancer. It's that common in men. The older we get as men, almost all of us are going to have prostate cancer. If not all of us, then a whole lot of us are going to have prostate cancer. It'll never cause us a problem. So if we find a prostate cancer, then what's really important is to understand what do we really have to do today about that cancer. And a lot of times, what you have to do is wait and just watch it. You don't have to have treatment. And other times it can be more aggressive and it has to be treated immediately. But those are, again, complicated conversations, and you should talk to your health professional about it, particularly if you're an African-American man, and particularly if you had a relative with prostate cancer. And some organizations advocate beginning at age 45, you should be talking about screening. The general recommendation is age 55 and over. But for African-American men, it's a more serious disease, and there may be more of a, shall we say, a tilt or a leaning in, shall we say, to getting tested for prostate cancer in advance.
So, Dr. Len, our chat has gotten very, very active. So one question that came in is, what kind of a physician do I see to get a lung cancer screening, to get the CT scan?
Well, you should start with your primary care clinician is where you should start to have the conversation. And they will refer you to a radiologist, an X-ray doctor, to actually do the screening. It's really important for lung cancer screening that you go somewhere to actually get that screening. You have to go somewhere that knows what they're doing, what we call high quality screening. And I assure you, there are plenty of places in New York City and outstanding institutions that know very well how to do lung cancer screening. But the first conversation about the pros, the cons, whatever, should be with a primary care clinician. There may be lung cancer screening programs run by some of the large hospitals in New York City. They should also, before they actually sit you down in the CAT scan, should have a conversation so you know what to expect and you know the importance of not only getting the screen, but also the importance of coming back for your follow-ups, which, as I mentioned, are every year for people who are active smokers and up to 15 years after you stop smoking, if you have stopped smoking in the past.
So there's a question, Dr. Len, about how is kidney cancer detected? What's the test to detect kidney cancer?
So there is no, again, everything we're talking about here, most part, for what we call people at average risk. Not somebody who has a strong family history. So there's some families that actually have history of kidney cancer that may be in their family, or there may be another genetic problem that follows in the family, and they're told specifically, you have to look for kidney cancer. We don't have a specific recommendation. When I say we, all the groups that make the recommendations don't have a recommendation for routine screening for kidney cancer. Lung cancer, colon cancer, breast cancer, conversations about prostate cancer, we've got recommendations on that, but we don't have a recommendation for routine screening for people at average risk of kidney cancer. What we do say, and I've said this a little earlier, I'll say it again, what we do say is if you see blood in your urine, go get tested, go see a doctor or a clinician, a health professional, because that could be a sign of kidney cancer. So here's the unique issue that's come up. We're doing a lot more CAT scans for things than for other reasons. And a surprising number of those CAT scans, a kidney cancer may show up. And sometimes that kidney cancer is very small. So even as we're having this conversation, recommendations are being developed on some of those things that we find what we call incidental omas or incidental findings. There are recommendations sometimes not to do anything immediately, but to watch them, and other times to do something right away because the kidney may have to come out. or part of the kidney may have to come out. So no routine recommendation for kidney cancer screening in people at average risk. People who have kidney cancer found as a result of doing a test for something else, making sure they're in the hands of a hospital or the doctors who really understand this, because you may be able to follow it. A lot of those kidney cancers that we're finding, nothing ever happens, sort of like with prostate cancer. We found it, but it's okay not to go ahead through major surgery. And other times you need major surgery right away. That really takes an expert, a urologist, and a urologist who's a doctor who specializes in these kinds of cancers. It takes somebody who's seen a lot of it to understand what the best treatment is for any individual if one of those cancers are found incidentally. But blood in the urine, that's an immediate. That there's no question. You go get care.
Dr. Lin, one of our attendees noted that they didn't see any mention of skin cancers or esophageal cancers leading to death in the stats that you presented. Does that mean they're not prevalent in men, or less prevalent in men than women?
Well, we did have a slide that got changed around a little bit that showed all the different kinds of cancers that happen in men, and broken down by different groups: white, Hispanic, and Black. So we didn't mention skin cancer, and skin cancer is actually an interesting topic. Skin cancer is far and away routine, typical skin cancers are far and away the most frequently diagnosed cancer in this country. Fortunately, most of them are very localized. But here's the message: if you notice a change in your skin, get it checked. If you see something that changes, get it checked. There's no formal screening recommendation for people at average risk. Some groups recommend routine screening, but from a high-level science point of view, ultimately the best thing is if you see a change, get it checked. Now, let's talk a little bit about people of color, because there's out there there's a thinking among doctors as well as folks that people of color don't get skin cancer. Not true. People of color do get skin cancer. And unfortunately, because of the feeling that they don't, that misconception, that misinformation that they don't get skin cancer, they can get skin lesions that are cancerous and can advance very far. So I don't care who you are. If you see a change in your skin, get it checked. Most importantly, and particularly for people of color, there are certain kinds of cancers that occur, and it's actually going to occur to anybody, but particularly in people of color, under the nail beds, on the soles of the feet, in the genital area. If you see a lesion, a dark, changing lesion there, please get it checked, because unfortunately, again, because of the misinformation, people tend to present very late in the course of that disease. And that can be melanoma, which is a more serious form of skin cancer. So bottom line, if you have a family history of skin cancer, you do need to get screening, and to get screened on a regular basis. So for example, my mom had skin cancers, and I've had skin cancer. So I go regularly to get screened. But we each have to look at ourselves. We have to be sure we look at our fingernails. We have to have someone look at the soles of our feet, look at our backs. And if you see a change, get it checked, no matter your ethnicity, no matter your race, no matter the color of your skin. If you see a change, you need to get it checked.
Dr. Lin, unfortunately, we only have time for one last quick question, and that is there any test for liver cancer?
The answer is there are tests that can be done if someone suspects liver cancer. So, for example, if somebody has cirrhosis, the chances are that they will have MRIs done on a regular basis. And there are some blood tests that may give an indication of risk for liver cancer. But in general, no, there is no specific. We don't do a generalized screen for liver cancer. But if you have cirrhosis, then you fall into a higher risk group or another liver disease, and there may be a screening test offered more often.
Well, thank you. All of those great answers, Dr. Len. And I think now you're going to move on to recommendations.
Which we've covered quite a bit. So let's go to the next slide, Rennie. We can. So we're really sort of summarizing here all the things we've talked about here in all the Q&A. Lung cancer screening, we've discussed at length. Colon cancer screening. You're in New York City, there's no excuse not to get colon cancer screening. Testicular examination, if you notice a change, if you're a man and you notice a change, you need to see a doctor. There's no routine recommendation anymore, but just as with breast cancer, you know your body better than anybody else does. If you notice a change, get it checked. Annual physical is probably what's is important about the annual physical is, do you have somebody you can identify where you can get your health care? Do you have a place that you go, somebody you see on a regular basis? And I'm going to step out of cancer for a minute. High blood pressure and diabetes certainly come to mind. And, we are not doing a great job in this country of taking care of high blood pressure and diabetes. I'm going to share, particularly with people of color, those are real issues. And we can prevent serious problems with heart disease, with stroke, if we take care of ourselves. Getting care from a regular source of care is critically important. Skin cancer screening, we've talked about. You see a change, get it checked. Prostate cancer screening, it says up to you, but understand that people of African American heritage, that there may be shall we say, it's not so much a bias, but a leaning in to get prostate cancer screening. In other groups, it's important you have the conversation because not every prostate cancer that's discovered needs treatment. Once again, if you're found to have prostate cancer, then get yourself in the hands of somebody who sees a lot of prostate cancer so they can help you make the best recommendation for your treatment. Next slide. And this goes back to something we talked about earlier when Trish asked the question, what can you do to take care of yourself? Watch what you eat. New York City is just a great place because there are a lot of places to get lots of really terrific food. And, we're all, particularly us tourists, the people who come in, we're all guilty of doing that, right? But eat a healthy diet. Don't go overboard. I made a comment about in Manhattan, the greengrocers were on the street. And somebody made a comment that, well, that's Manhattan. It's not everywhere. Hopefully you have access to healthy food. Take advantage of that. Fruits, vegetables, less red meat, you'll be better off. Smoking and alcohol we've discussed. Checkups we've talked about. Healthy body weight, which is really tough, including for me. I know how hard it is to try to do that. Exercise, make sure you stay active. Those are all parts of a healthy lifestyle, and knowing your family history. And that's tough. I don't know all my family history. And for many of the folks who are listening to this call, you may, not many, I don't know, it's an unfair statement, but for some of you on this call, you may have difficulty knowing your family history, but to the degree you can get that information, get it, use it, share it with your clinician. Sometimes you may need additional tests to find out if you have an abnormality in your genes that might indicate you're at higher risk of certain cancers. Next slide. So additional resources in the next slide, I think that goes back to Trish, Rennie. I think that that's for you.
Thank you so much. So with the additional resources, definitely we have within New York City government, we have a lot of different sources and stuff like that you could talk, we could get you in contact with, especially within New York City government. And if you have your own PCP, so definitely reach out to your PCP on anything else. Trish?
Sure. So as I mentioned earlier, I'll tell you just a bit more about cancer care services that are available to everyone free of charge. We have a program that we developed during COVID called Resource Navigation. This is an intense program designed to help individuals find the resources that they may need in their community, whether that's transportation, financial assistance, legal assistance. And so we work with the clients to get you the resources that you need. We provide individual counseling by highly trained masters prepared oncology social workers. We have support groups that are face-to-face, online, and telephone. We typically run nearly 200 support groups each year that are disease specific, population specific, so they're always available to you. Coping circles, these are workshops that are a bit more intense than the support groups that focus on different areas and work with people, with individuals that have been diagnosed with cancer and their caregivers. During COVID, we learned that people accessed information in many different ways. We created a Cancer Care podcast series. We're now just launching season 6. We've had over 12,000 downloads of our podcast since we launched. We have very robust educational workshops called Connect Education Workshops, typically 75 to 80 a year, that are many times led by key physicians across the country. We can focus on specific disease areas, understanding and helping symptoms and side effect management, legal issues, caregiving, etc. There's a variety of these programs. Out of them comes publications that are online, available to download, or available in print. And we, last year, as an example, we distributed just under 2 million publications. We have a variety of financial assistance and co-payment assistance programs for individuals to help afford transportation, childcare, your medication. Last year, we gave out almost $80 million in financial assistance. So Cancer Care is here for you and your loved ones. And I'll turn it back to you, Rennie. Thank you.
Thank you for that. Next slide is the EAP. EAP is so important to us, to the work that we do at Work with NYC, and for all New York City government employees. Is something that's very underutilized by a lot of New York City government staff, and we always tell people it's a huge help. If it's basically all the services within one place that they could get into contact with. There are people that have gotten counselors through this, find doctors they couldn't find before within their networks. It's such a great help for you and your family. It also, your family falls under this also. You could find help for your family within the New York City EAP program. And I've done a good job, a great job of hiring much more staff that looks and recognizes the New York City employee base. So EAP is a very, very important program for New York City employees. Also, we have a few great upcoming events in the kitchen with Workwell NYC. Pretty cool stuff. I just recently had one for ACS. There was one last night, and we do this for New York City government workers. Every so often, there are all these great programs that we do, and it's all geared towards just having a healthier workforce. Hey Thanks Challenge coming up December 12th and 16th, and everybody's able to get these stuff for just their work sites. I'm trying to get this challenge to every single ACS work site under me, so I'm trying to get that done. And also the Power of Gratitude, December 15th, sorry. It is super important that we show gratitude in every way possible. Gratitude makes you feel better about yourself and about the work that you're doing, especially in supporting the New York City community. So as always, first, I'd like to say thank you to Cancer Care. This is like my third workshop with you all, and it's always great information. I also do a class from folks every Wednesday, and I actually spoke about cancer this week. So this was really great for reinforcing a lot of the information I did yesterday to my folks. So thank you so much. Please check out the Workwell website, contact us. We are on Instagram, YouTube, LinkedIn. We have a lot of great resources, and the slides will also be available to everyone after this workshop. And again, I'd like to say thank you, Dr. Len and Patricia. If you have anything else to say before, we still have a few minutes.
No, just thank you, Rennie, for giving us this opportunity, and thank you, Dr. Len, as always, for being spectacular.
Yeah.
Well, I appreciate the opportunity to be here, but message for everyone: take care of yourself. Nobody can do more for you than you can do for yourself, and you can make it happen.
Wow. And we just want to continue this great relationship with Cancer Care. You're always welcome to come back over and over and over and over again. Thank you so much. Say hi to the animals, the dogs and stuff. And Thank you everyone for joining us, and I hope everybody enjoy the rest of the day, the week, and have a great weekend coming up, and a great Thanksgiving weekend. All right, great Thanksgiving.
Wow.
Thank you, everyone.
Be well, everyone.